And I'd like to now introduce our first speaker, Dr. Nancy Phillips. Dr. Phillips went to medical school at Rutgers Robert Wood Johnson, did her residency in OBGYN at George Washington University, and she is currently an associate professor of OBGYN at Rutgers Robert Wood Johnson. Her clinical interest is in vulvovaginal health, and she is going to speak to us this morning on female sexual dysfunction.
Good morning. I'm going to start off by saying the introduction in the brochure is a little bit different than what I'm actually speaking about today, because last year I did a talk on female sexual dysfunction, and I didn't want to be repetitive from last year. And I thought this year I would have so much more to say with the introduction of flibanserin and things like that. So because I didn't really have a whole lot to add about that based on what was going on, and we'll talk about that a little bit, I changed my talk a little bit, that we're going to talk about medical practice versus medical politics, kind of with female sexual dysfunction as a background. But I'm going to start off with I have no disclosures. I hope to not really teach you something, but kind of have you think about things. And this talk is intended to raise questions and not answers. So I'm going to go a little bit away from the female sexual dysfunction talk, but if anybody has questions about that, because I do a lot of that, that's fine as well. So medical practice versus medical politics, what do I really mean by that? I'm going to talk about flibanserin. I'm going to touch on over-the-counter birth control pills, just to raise some questions about that. And then I am going to do a quick update on female sexual dysfunction, because I just can't help myself. So what do I mean by medical politics? Just by virtue of what we do, we're stuck in between medical practice, a lot of ethical questions, and whenever there's ethical questions and there's debate, somehow politics gets into it, and there's policies, and there's laws, and there's regulations. So between the things that are happening, and this is not only current, but throughout medical practice, but right now, think about it, we're in the middle of controversies about marijuana, euthanasia. Yesterday we had a great talk about all the breast cancer screening controversies, Obamacare, abortion, which goes on and on. So we're kind of thrust in the middle of these controversies, whether we like it or not. But it's not new. This I found very interesting. This is the FDA approval for birth control from May 10th, 1960. And if you read that, it says, we have no choice as to the morality that might be involved. When the data convinced our experts, approval was based on the question of safety. So even when they initially approved it, they talked about the ethics of it, but they approved it based on the safety. Now, it's funny if they would be able to say the same thing about flibanserin if they wrote that article today. And at the same time, back in after the pills were out for a while and you started seeing that they were causing problems, it was in 1970 that feminist groups challenged the safety of the pill. And similar to what was happening with flibanserin, they said, wait a minute, if this were about men, would you be doing the same thing? So history kind of tends to repeat itself. And I found this interesting. I never knew this. It was not until 1972 that birth control could be given to people who weren't married. It was deemed a right for all women. This brings us to flibanserin, the politics and the medicine behind flibanserin. How did that get approved? Should that have been approved? That's an ongoing debate. And I think, unfortunately, that ongoing debate may be part of what has made flibanserin not very successful. It was initially developed as an antidepressant. It acts centrally in the serotonergic, dopaminergic axis, although nobody really knows how it works. It's not effective as an antidepressant, but what they found in the preclinical studies was that it improved desire. It was submitted to the FDA in 2010, But they denied it, saying that the risk versus benefit wasn't there. And the reason they denied it was because there was not a statistically significant increase in desire the way the data was presented. And the side effects of the nausea, the hypotension, the syncopal episodes they thought was too great of a risk for the benefit. So they resubmitted it to the FDA in 2013. It was denied again, asking for more safety data. But what happened here? What happened between 2010 and 2013 that it got resubmitted? Well, for one, it got sold from BI to Sprout Pharmaceuticals. And for two, they changed the data a little bit. The FSFI, everybody's familiar with the female sexual function inventory. It's a, I can't remember, 17 or 19 question survey that looks at the 4 domains of sexuality. What they did was they changed the way they presented the data from a daily reporting of desire. So women were instructed every day to write down how they ranked their desire. And when they did it day by day, they didn't notice a statistical significance, so they changed the data to just make it the average over the course of the month. So they didn't really do anything different, they just represented the data. So they represented the data to the FDA, and the FDA said, okay, well now maybe it's a little bit more significant, but we want more safety information. 1 related to alcohol, and 2 related to driving. So they did driving tests, and they did alcohol tests, which, as you probably all know, was done on about 25 people, 23 of whom were men. What they had to do was drink 3 shots of grain alcohol in rapid succession first thing in the morning, and then take either a flibanserin or a placebo. And they noted that more people were dizzy and passed out with flibanserin than placebo. So how that translates into real life is hard to say. How that translates into women is hard to say. But for some reason, the FDA took that data, accepted that data, and said, okay, we're going to approve it, but we're going to have a lot of conditions. It's approved for hypoactive sexual desire disorder, but there has to be a REMS test, which is a risk evaluation and mitigation strategy, that if physicians want to prescribe it, they have to take the test, they have to pass the test, and then there's a consent that you have to give to the women before you give them flibanserin. And this consent is mostly based on the fact that the advice is to not drink any alcohol while you're taking flibanserin. Flibanserin is not an on-demand drug. It's an everyday drug. So basically, you sign up to take flibanserin and stop drinking alcohol at all. What happened, I'm going to go back. What happened between that 2013 denial and that 2015 approval, besides a study of 25 men who drank alcohol? Was the politics of flibanserin. There was a large movement, again, the women's groups, calling the FDA sexist for not approving the female Viagra, which is very misleading, because flibanserin is not in any way like Viagra, right? Different indication, different mechanism of action, not an on-demand drug, and doesn't have the same efficacy that Viagra has. There was an organization that formed called Even the Score, which was made of 26 different women's organizations. They had websites, they had petitions, they were very, very politically active. So the question remains, was it really flibanserin approved because it was a good medication? Or was it approved because of the pressure on the FDA? Did they kind of bow to the political pressure? What's interesting is that Even the Score was actually initiated by consultants who were working for Sprout Pharmaceuticals, who owned the drug at the time. So what is the overall efficacy? Now that we have a little bit of data and some meta-analysis that's been done on flibanserin, There was a recent systematic review and meta-analysis, 5 published, 3 unpublished, double-blind, placebo-controlled trials, about 6,000 women. Flibanserin added 0.5 additional sexually satisfying events each month versus placebo, and a small improvement in measures of self-reported sexual desire. So 0.5 additional sexual satisfying events for a medication you take every day that has significant side effects and for which you have to say, I'm not going to drink any more alcohol. I couldn't do that, I don't know, for a week. And the side effects, the risk ratio for any of them the risk ratios were, 3-4 times the amount of dizziness versus placebo. But I haven't has anybody seen any severe reactions? I haven't seen any case reports of deaths or rapes or severe reactions. Maybe it's because not enough women are taking it. Maybe because physicians are really prescribing it to appropriate people, which I hope is the case. So I think the jury is still out. I don't know the answer to the question. I don't know the answer to the question of was this approved because it was a good drug? If this was a drug for something other than sex, if this was a drug that had that kind of efficacy in any other field of medicine, I'm not sure that drug would have been approved. That's what I kind of mean between the politics and the medical practice. So I thought, okay, when we had cards, I didn't know they were just yes/no cards, so I know people have been having trouble holding up a yes or no. I thought there were going to be 4 cards, because I was at a conference once where there were 4 cards. So I have a lot of 4 questions, but have people prescribed flibanserin? Has anybody prescribed it? Okay.
1 prescription, and I'm pretty sure she didn't fill it.
Okay. Have people taken the REMS program? And have you tried to prescribe it? Because and that's what I was going to use the catch box to have people give us feedback, some patients who had used flibanserin. I've prescribed it 4 times. The other thing that I didn't write in here that I should have was that it's only approved in postmenopausal women. So that's a big drawback. I've prescribed it 4 times. Twice was to premenopausal women, and twice were to postmenopausal women. I have one woman who is one of the kind of perimenopausal women who's probably postmenopausal, but she has a Mirena, so I'm not really sure. So I figured I could get away with that one. And she loves it. She said that it has increased her desire. She feels fantastic. And then the 3 other people I never heard back from, so I believe they probably just didn't fill their prescriptions. Do I tell people, again, when you read the study, when you talk about the way they prescribe the alcohol, absolutely no alcohol, I talk to them about alcohol. I tell them to make sure, again, you have to choose your patients. I don't say it's okay to go out and binge drink. I think if you're with your spouse or your significant other, you're in a safe situation, you're not driving, you're not in fear of being raped, you're not in fear of really a bad outcome. If you do happen to faint, I think it's okay to have a glass of wine. And that's where I leave it. I don't know that there's been a lot of data. The interesting part about alcohol is when they did those preliminary studies on it was 1,200 women who were in their original trial, they described themselves as moderate drinkers. So they weren't restricting alcohol during the original trials. So we'll leave flibanserin is kind of up in the air. It'd be interesting to see what happens to it. Why do you think flibanserin failed? Again, I know I can't have a show of hands, but I think all these questions are right. And when I have given this talk before about medical practice versus medical politics, I've done it as a debate. Usually I've had somebody else with me to debate. So up here I'm going to try to be 2 people and kind of go from one side to the other. So, was it that we didn't need a sex drug? Did it fail because of safety concerns from the patient, safety concerns of the physicians, or was it cost? So people who are pro-flibanserin will say, well, we did need a sex drug. There was a need. And I kind of agree there was a need. How many times does somebody come in and say they have low libido? Does that happen? It usually happens as they're walking out the door. Oh, by the way, I had one other question. I have no desire. The safety concerns of the patient. Well, maybe they think it's worth it. Maybe it's my relationship is in trouble. Maybe I want to feel like I used to feel. Maybe it's worth it to think I may be dizzy once in a while. The safety concerns of the physician. Well, I can counsel my patients. I can provide informed consent. Let them decide if it's worth it. And the cost, again, it's a matter of priorities. If it works, is it worth that money to save a relationship, to feel like you used to in your relationship? People who are anti-flibanserin says, this is just another one of those designer drugs. There are too many real medical problems to treat, not only locally and in the U.S., but globally. Why are we spending billions of dollars on a sex drug when there are people still dying of HIV because they can't get their medications, or there's so many things that we need to treat? Is one more satisfying sex act, is that really worth? And in the meta-analysis, it's actually 0.5 satisfying sex events. I don't know what half of a satisfying sex event is. For physicians, it's really not worth my liability. It's not worth my time. It's not worth my counseling. Or, and I like this one, spend the money. If you're going to spend $800 a month, spend the money on a nice hotel and a bottle of wine. You'll get one more satisfying sex act that month. Or, better yet, maybe spend the money on a counselor. That might help a little bit too. So, the debate goes on. Has anybody used a drug with a REMS program before? I was surprised to know that I had, although I had no idea it had a REMS program. These are some of the other drugs that have REMS programs. I don't recall ever taking a test for them. I don't recall it being all over the news for them. Does anybody else? And what's the future of flibanserin? As soon as flibanserin was FDA approved, it was sold to Valiant Pharmaceuticals for $1 billion. They're the ones who made the price $800 from what it was projected originally to be $400. Not that that's great, but it's better than $800. And they jacked it up to $800 a month. Sales to date are about $11 million a year, estimated to be $150 million a year. Valiant is about to relaunch flibanserin. I'm not sure exactly what that means. I think there's going to be a major, I don't know if it's an ad campaign, if they have new data that they're holding back, or if something else is going on. But I think it's interesting, and we will see. I was so hoping this drug would work. Weren't you guys all hoping this drug would work? We were all hoping. So I'm going to change course a little bit. Over-the-counter birth control pills, patches, rings. Where are the debates about those? Has anybody heard big controversy, debates, anything about that? I thought this was going to be one of those medical practice politics things, but it's really not. In January, Oregon became the first state to allow over-the-counter birth control pills, and then California and Washington State followed suit. Maybe I'm overestimating the importance of my job, but that made me kind of a little bit nervous. They do have some regulations. They require a visit to the pharmacist, who must be trained, a completion of a 20-question health screen survey, and a blood pressure measurement. So that's pretty good, right? I think that's going to screen in or out most of the people who are going to have a problem. So where's the debate about that? Okay, again, I think in my mind there's three things about going over the counter, three reasons that are cited, actually not my mind, three reasons that are cited. Safety, risks, and access. So if you're pro over-the-counter, there is a questionnaire, and they are doing a blood pressure check. In some ways, I think that they might do a better job with a 20-question questionnaire than we sometimes do in our office. How many of you see a patient who comes to you as a new patient for a refill of her birth control pills, who's 42 and has migraines, or 32 and has migraines with aura, or 25 and has migraines with aura? The migraines is the one that sticks in my head because that's the one that everybody always says, oh, it's okay, it's just a migraine. Maybe it's only once or twice. Maybe the pharmacist will be a hard stop. Migraines, no pills. Maybe it'll be better because they won't kind of squeeze people in under the wire. The risks are probably minimal in most, right? We've all been prescribing birth control pills, probably the most common prescription I give, and I have seen very few really serious adverse events. And it does give access to underserved, low income, or just busy who can't get to a doctor. And it may help continuation rates of birth control pills. Tomorrow I'll talk about LARC and review kind of the abysmal continuation rates of birth control pills. Obviously, they're not doing a great job in preventing unintended pregnancies because we have so many unintended pregnancies. But if I don't know where I stand on this issue, and again, this is one of those I'm happy for feedback. Anti-over-the-counter, it's not really a complete evaluation. I didn't see anything about limits on the duration of use. I don't know who's doing the STI screens, PAPs, mammos. Is anybody reminding women about that? Is there somebody who's counseling? And in terms of access, there is Planned Parenthood. There are clinics that have availability for underserved and low income. I think part of why there's not a debate is because ACOG is for it. ACOG says, and this is a statement from 2012, weighing the risk versus the benefits, oral contraceptives should be available over the counter. And maybe that's why there's not a lot of debate about it, because we already have ACOG on board. But I think there are some considerations, and I'm happy to hear what people think. Should there be an age restriction, upper or lower? I didn't see anything about an age restriction. Should a physician visit be required after a certain age, after a certain number of years on the pill? Can you take the pill for 15 years without ever seeing a doctor? I don't know. There goes our cervical cancer screening, our mammograms. Will we see an increase in untreated STIs, tubal infertility, ectopic pregnancies, pelvic pain down the road if we have a lot of undiagnosed chlamydia running around? And what will pharmacists charge for the service? Will they be able to charge for the service? Will it be covered by insurance? Will it be controlled by insurance? And is this the first step of moving things out of our offices and into the pharmacist's office, which is happening? You can see that tide coming, right? So I think those are a lot of questions that I have. I'd like to hear feedback. If anybody thinks this is a great idea, if they have concerns, what do you think? Is anybody here from California, Oregon, or Washington? I know we're kind of on the other side of the country. People are as undecided as me. Okay.
I mean, birth control pills have always just been one of those hooks to bring a patient in annually, and you can talk. I mean, it ends up being conversations that range from smoking cessation, managing your blood pressure, getting them into primary care, getting the screening tests. And it makes me nervous thinking about it. Because so often, even pretty reliable patients, what makes them come back in is they need pills refilled. And I can see even some of my long-term patients going 3, 4, 5 years without coming in if they're just able to fill their pills at the pharmacy.
Yeah, see that's I agree. I agree that the pill is a hook to get people back in.
I see those points and I think they're very valid, but I come from Oklahoma, which is a state with the highest teen pregnancy rate. And a lot of it is access and teens not coming in. So I see the benefit from teens who would access this and use it. And just in the last month, now I've been practicing for about 14 years, and this is the first time that I've really been aware of it, but in the last month I've had 2 patients who ran out of their pills, were seeing a different provider, wouldn't fill them over the phone because they didn't come in, and I've seen them now for their new OB visit. So I think that the benefits I tend to agree with ACOG, the benefits outweigh the risks, and I do think your points are very valid, but I think patients will come in with continued education, and we've got to decrease this unwanted pregnancy rate, and there's not another way to do it. It's my point, 2 cents.
Well, I don't disagree with that, and I like I said, I can see all points of that, but I do wonder if there should be, should a physician visit be, number 2? I mean, should you be required to see a physician after a certain age?
Maybe.
What if you're 44?
Yeah.
And you are perimenopausal, and your friends who are 45 tell you, well, go on the pill, it'll be great. Should there be some more restrictions on it? And that doesn't mean stop the pills. I always hate when I hear stories like that. People get pregnant because their physician wouldn't refill their pills. I think that's silly to not refill a pill because somebody hasn't come in.
I also just have this thought in the back of my head about people for victims of sexual trafficking and how easy it might be for the bad people to get access to this.
That's true. People can be forced to take it. That's right. It's putting the control over somebody else.
It's just another thought.
No, that's a good thought. There are lots of downs. There are lots of ups. I mean, it's going to happen, and I think overall it's probably a good thing. But I do think it's something that is just, in my mind, it's just there's so much. Everybody's up in arms, and there's so much talk about, flibanserin, which is so regulated, and then this is just going to kind of sneak in under the wire, and it just worries me that there's not going to be anybody really kind of looking at it to say, what should we be doing about this, or how can we make this safer for women?
And Title 10 gives free birth control pills to people all over the place in every state. What does Title 10?
But in a state like Oklahoma, we have very limited Title 10. Again, that's the problem. They're being closed right and left.
Oh, okay. I'm sorry. Some of the, as we go forward, I'll repeat questions. I'm sorry, because some of them aren't getting picked up. The one question was about increasing the ease for trafficking and women who are being forced to be sexually active, that somebody else can now be in charge of getting them their pills. It may just make it a little bit easier. Okay, I'm going to keep moving. Okay, now I'm going to go to something totally different, a little update on female sexual dysfunction. This is just a couple things that are new and different that you may be seeing or hearing about, and some of them are just kind of for interest's sake. Fiera, has everybody heard about the new little mechanical sexual arousal device called Fiera? It is made by Newell. It costs $250, which is significantly cheaper than flibanserin. It is, I should have brought, I have a sample one. I should have brought it with me. I forgot it. It's about this big. It looks like a little snail, I have to say. And when you look on the flip side, you can see that there is suction cups. And not only do they suck, they vibrate. It is made to put over the clitoris. Has a rechargeable battery, and it can stay in place during intercourse. So it is multifunctional. It is not marketed as an orgasm device, but it is marketed as an arousal device. And the reason it is marketed that way, and I know this is a really, really busy slide, But the bottom line is it's showing these are thermograms of blood flow before and after 5 to 15 minutes of having Fiera applied to the clitoral area. This first picture is premenopausal women. This second picture is postmenopausal women, which accounts for the decreased overall blood flow that's there. It is not an FDA-approved device. It is, quote, not intended to treat any medical condition. It probably is just a little bit more medically advocated vibrator kind of device. It is tested in not a whole lot of people. The studies that were done were not in a whole lot of people, and they were people without sexual dysfunctions. However, it is something that should be in your consciousness for women who are looking for increased arousal. I recommend vibrators to women a lot. Sometimes I think I would make more money if I sold vibrators in my office out in the lobby than if I actually did the counseling about sexual dysfunction. But this is actually a nice little device. The fact that it can stay on during intercourse, I have not had a lot of feedback about it. I do have a funny story, and I'll talk about this when I talk about sexual menopause and lubricants. You have to know your products that you're telling people to get. You have to know where to get them. You have to know how to get them. Yes?
I'm a little older, so this question, why not be French and just use your tongue? I mean, why do you need that thing?
Well, because sometimes the question was, why not use your tongue? Why not use manual stimulation? Why not? Well, because sometimes that's not enough. Sometimes women, especially with arousal disorders or trouble with arousal, whether it's secondary to medications or postmenopausal, sometimes they need more stimulation for a longer time to reach the same point. So it's just a sexual enhancer device.
Okay, I mean,
I understand. It's good to know things are out there that you can offer people. It's the Eros device, which is the only FDA approved. It's like a little suction cup that goes over the clitoris. It's for arousal orgasm. Well, I prescribed that to somebody several years ago, and this is how I decided that you really have to know about how to tell people to get things. So I always tell people how to get vibrators, how to get things. But I didn't tell this woman. I wrote her a prescription. I said, it's FDA approved. You write a prescription, you go to the pharmacy, they give it to you.
I think next thing it'll be an app on your cell phone. Just
you might have something there. The suggestion was an app on your cell phone. I'm not sure about the hygiene of that,
I think Apple could make it.
I think Apple probably could make it. Maybe we should make it. We'll talk afterwards. But this woman has subsequently had to change pharmacies because she took the prescription in. She gave it to the 18-year-old guy behind the pharmacy counter. He took it to the 23-year-old pharmacist. Nobody knew what it was. They're announcing it. It's like one of those bad commercials where they're announcing over the loudspeaker how much for the tampons, how much for the orgasm stimulator for Mrs. So-and-so. So try not to do that to people. Fortunately, she had a good sense of humor about it. I don't think she ever got her stimulator. So these you can tell people to order online. It may be over the counter in a pharmacy someday, but order it online. There are other things. They do sell little rings and things that you can put on as well. This is also a new thing, emotional intelligence in sex. And the reason I bring this up is because in our institution, we've started having lots of grand rounds and talks and instruction on emotional intelligence. What's emotional intelligence? Apparently physicians don't have a lot of it.
No.
We don't. My husband's been telling me that for years, but now it's confirmed. It's the capacity to be aware of, control, and express one's emotions judiciously and empathetically. I think we're pretty good with our patients in terms of that. Sometimes we're not so good with the other people around us in hospitals. I have to say that we have had a lot of lectures on this, and they're talking to us about this a lot, and part of me thinks it's just another way of saying, just shut up and take it. Like if you could handle this the right way, you can deal with the EMR and the patient loads and all this stuff. But there is something to be said to it. So whenever anything is new, they always have to look about how does this affect sex. So you would think the more emotionally intelligent you are, the better your sex life, right? Wouldn't you think, if you can handle your relationships? Well, apparently women with a high EQ are more likely to be orgasmic. That's really good, but they're less likely to have desire, and there's some association with quality of life. No association at all with sexual functioning in men. So my conclusion that's all the update I have for female sexual dysfunction. That's all. There's no updates. There haven't been updates other than flibanserin for like 100 years. So my conclusion is my same conclusion as last year. Women are complicated, and that's going to make it really hard to find sexual drugs for women that are going to work. But I'm not done yet. One more thing to cover. Robotica. You can now be robosexual. David Levy imagines that by 2050, human-robot marriages will be pretty commonplace. It's like that movie where the guy was in love with his cell phone. Just imagine that. Matt McMullen is making that happen with his company, Real Dolls. How many people were here last year? Do we have a couple? Do you guys remember these are sex bots. Remember those from last year? These are real dolls. $5,000 to $6,000, interactive, customizable. And Matt McMullen, who designs them, says, I want people actually develop an emotional attachment. He wants people to be in love with these robots. And the question I had at the end of my lecture last year was, do they make men robots? So, meet Nick. I chose one who was actually clothed and in a semi-decent position. But if you go on the website, by the way, don't try to do this at your institution if they monitor you, because you will be blocked, as I was. But there's lots of them out there. Now, there's a campaign against sex robots, just to let you know that everything has its opponents. And the argument is it sexually objectifies women and children, it reduces human empathy, and it can reinforce power relations of inequality and violence. Okay, and there is a huge campaign against making these sex bots and having, especially men, there are a lot of women's groups coming out saying this is just another unequal relationship. But again, remember Nick. Okay, and then this is my favorite quote of all, and this is how I'm ending this. When you introduce a low-cost alternative to women that comes without all the nagging, insecurity, and expense, frankly, men are going to leap in head first. So there will always be a controversy.